I'm going to talk about hospital electronic health records data, relatively novel research resource, maybe not quite as novel as it once was, but I'm going to talk about it in the context of ageing research and academic geriatric medicine. And my interest, as Genevieve alluded to, is really around the inpatient experience of older adults and the particular challenges that they face. So these days, more often than not, I'm asked to give lightning presentations that last 4 minutes, and you've asked me to give a presentation that lasts 40 minutes. So to ensure that it will get lost, I thought I'd start by giving an overview. So I'm going to start with a bit of background, a very brief case vignette to set the scene, a bit about what I do as a core part of my clinical work, in case people don't understand what a geriatrician does, and that's the comprehensive geriatric. And then I'm going to explain why a geriatrician like me bothers about research. What is it that motivates me to get out and do things outside of my clinical discipline? And really, it's around trying to better understand the inpatient experience. And in that regard, I'm going to talk about and walk you through some of the work we've done, utilising data from the electronic health records we have in Cambridge for both service evaluation and research studies. And I'm going to take a bit of a headlines approach in order to sort of weave a story. So if you want to ask more detail, I think there is a Q&A session at the end where we can go into things in a bit more depth. And then at the end, I'm going to reflect on this hospital EHR data resource. Is it an opportunity for ageing research? What are the pros and cons? So this is my case vignette. It's not actually based on a real patient, and yet it could be almost anybody I've seen in the last couple of weeks on the ward. I've chosen to characterise her as an 82-year-old woman who's admitted with shortness of breath. She's living with multimorbidity. That's 6, I think, long-term conditions listed there. It's not really surprising. Half of adults over 60 years old are living with multiple long-term conditions. Consistent with that, she is taking up to 16 doses of different medications per day. Again, not really a shock. A third of all prescribed medications are taken by patients aged 75 years and older. And in terms of her functional state, she's mobile with a rollator frame outside, a stick inside, but she rarely leaves the house in which she now lives alone. And her daughter is increasingly supporting her from afar. I chose to put the daughter in Oxford. The weekly shop online is done by the daughter, and she's also increasingly helping to manage things like finances because of what she reports as mum's increasing forgetfulness. We measure frailty in the hospital using a clinical frailty scale score, and she's definitely scoring at least a 5, mildly frail, but I think if we dug a bit deeper, explored that forgetfulness, the impact that's having on her dependency and her functional state, she'd probably make a 6, especially considering that she's now rarely leaving the house. So she's someone who's got multimorbidity, polypharmacy, and probable moderate frailty. Now, the things that tipped her into hospital, they're picked up pretty quickly in the A&E. She's got decompensated heart failure and pneumonia. Those are the 2 things that have tipped her into hospital and presented with that shortness of breath presenting complaint. But you kind of get the impression from the way I've told the story that underneath this, there's medical complexity and there's a bit more going on behind the scenes and these things that just tipped her into hospital. So almost anybody in the hospital could look after this lady, all trained to look after heart failure and pneumonia. But how can we ensure that this patient and those like her get the best health outcomes from that inpatient episode? And that is what brings me on to comprehensive geriatric assessment, because this is what I do as part of my day-to-day clinical work. And it's essentially a holistic review. And I think we'd all agree from what I've just presented, that's what this lady needs, is a holistic assessment. And CGA is by definition multidimensional, interdisciplinary. It tends to be led by a consultant geriatrician, but the aim is to go through all the different sort of factors that are impacting on that patient's health, from physical, socioeconomic, environmental, functional, mobility, psychological and mental health conditions, and then to perform a medication review as a core part of that review, to create a problem list, a personalised care plan specific to that patient that will then inform what interventions are needed. And you regularly review this and plan that regular review. In primary care, that might be every year or every few months. In secondary care, it tends to be daily. We have a daily multidisciplinary board meeting to review that patient's care. And really, I've been doing CGA without knowing it almost my entire career. It was very natural to me to do this, but it was conceptualised and formalised and researched out of the concern that many health interactions were not meeting the needs of older patients. There was too much focus on the tipping points, the things that brought them into hospital, and not enough focus on all the other things that were harder to find but were really important. And we now have a number needed to treat. So we know that if this patient is looked after on a ward delivering CGA led by a consultant geriatrician versus usual care, if we treat 20 patients like this, one I've exemplified to you, will save one person from unnecessary death or institutionalisation at 12 months. And that's work done by Graham Ellis in a Cochrane review updated in 2017. That's good. I don't need to do any research. It's all done. We can just do CGA and everything will be fine. Well, it's not quite as simple as that. Obviously, within the structure of CGA, there are lots of unknown and decisions around specific aspects of treatment that we need to resolve, which medications are right for this patient at this time, etc. And within CGA itself, we don't always know with certainty whether it has to be delivered in a ward-based setting, whether it could be mobile teams going around the hospital, whether we should have an age-based criteria, so delivering it to all older adults, or whether it should be on need, so led by criteria like the frailty score. And that's important because we have about 12,000 older adult emergency inpatient episodes per year in Addenbrooke's. There's only about, I think, 12 full-time consultant geriatricians, so we can't look after everyone. I think some of this uncertainty around these questions also reflect a wider uncertainty around what's happening to these patients when they're in hospital and their experiences, which are generally poorly understood because they're underserved by clinical research, undoubtedly. They're often excluded because of their medical complexity from traditional research studies and opportunities, and they're also excluded because they tend to be living with equity factors. And I'll explain a bit more about that in a minute. In fact, I wrote a blog about inequity in research and linked to inequity in healthcare as part of my role as part of the trauma study team, which was not directly related to my work with electronic health records research, although the trauma studies take advantage of the ubiquitous electronic prescribing in hospitals. But many of the lessons and challenges I describe in the blog are equally applicable to why I'm motivated to do work with electronic health records. So the blog kind of focuses on this editorial in Age and Ageing, which is linking inequity in research to inequity in healthcare. And it's based around a systematic review around rehabilitation interventions after hip fracture. And what that review found is that many patients are excluded from being participants in these trials based on equity factors. So things like advanced age, place of residence, living in a care home, disability, having cognitive impairment, these kinds of things. And shockingly, over 2/3, 80% of trials of interventions after a hip fracture exclude patients with cognitive impairment, despite the fact that 1 in 3 patients admitted with a hip fracture has cognitive impairment. So it's raising the concern that the research population is not matching the patient population that downstream that research is ultimately intending to serve. And that's, like, as Mike discussed in his editorial, raises the possibility that inequity in research might inadvertently be driving inequity in healthcare. Because if we have vulnerable groups defined by equity factors, having a lower participation in research, less opportunity then to develop downstream treatments and services developed as a result of that research, less opportunity to achieve the best outcomes possible, they further then marginalise from mainstream healthcare and research opportunities. That's going to drive a sort of cycle that we don't want in terms of the access to research and equitable healthcare. And if the NHS is constitutionally committed, as it is, to providing evidence-based care, this does present a very real challenge, because if we don't have the evidence to underpin the services, then we can't, according to the NHS constitution, deliver them for our patients. So this is what really drives me to try and include in any way possible our older adults and hard to reach and hard to represent populations in the research outputs. So that was just one subject area and one review. But if we look across the NHS and the CRN network, although 100% of trusts and over half of GP practices are contributing participants to research studies, when we dig down to the detail, only around less than 3% are recruited to studies with ageing as a named specialty, and even less than that with ageing as a primary managing specialty. And that's a potential inequity in access based on age. And the NIHR sort of take that seriously. And I don't know if you've heard of the Year of Birth project that's been rumbling along for a while, but the NIHR are actually trying to record information about all of their study participants recruited to CRM portfolio studies. It's a piece of work led by Dr Anwar at the NIHR, and I'm limited to the data that she gave me. This is the slide that she provided, which shows that in the interim data they gathered last year, the age range of participants recruited to studies of cancer is significantly different in distribution. That's the age range detailed by the red bar chart, from the age of patients with incident to the age at diagnosis of incident cancer, which is the thin blue line. And so if we've got this disparity between patient and research populations, how can we be sure that we're going to be able to develop the interventions and systems to really match the needs of patients downstream? So this is very much about equity of access to research, leading on to equity of access to healthcare. So based on that, this is what really drives me to see whether hospital electronic health records have the which offer the potential and promise of really including those hard to reach and represent populations in research. Can they really do that in reality? So whatever trust information system you have, even if it's something like EPIC, which is badged as being very comprehensive, the first thing you understand is that it's not going to be tailored to the needs of older people. In fact, it's not going to be tailored to the needs of any specialty group. It's just a generic record system. So you have to embed yourself into your digital healthcare team or e-hospital, whatever it is. And then you have to embed those metrics and components that are important to you, your patients and your specialty in that record system. And in our case, that was obviously embedding a digital record of CGA, particularly focusing on frailty and low frailty syndromes that we thought were likely to be important. You then have realised that this is a great system, a great record. It's not going to do the clinical assessments for you. So you have to develop systems and processes to support those assessments being made and then entered into the EHR. And then you then have to develop the systems and processes to assimilate that information to facilitate important communications about that information. So, for example, in our case, it's very much about interfacing with the community and getting those discharge summaries right. That information is passed back to the GP. Once you've done all that, obviously you've got a really ideal opportunity to show that you've improved the quality of care through better standardised documentation and improved communication. But you've also created the infrastructure to then retrieve information at scale about metrics that are really important for your patients that perhaps have not been available before on this scale and size, both for service evaluation, audit and also for clinical research. So we started, and I'm sorry for people who've seen this 100 times before, but we started, and actually this was a colleague of mine, Raymond Martino, who's now a professor at Trinity College Dublin, evaluating whether it was useful to measure frailty in our patient population. And this was actually pre-EPIC. So I think there's an important message there. You don't necessarily have to have a totally ball singing, dancing electronic health record system. All trusts will have some information management systems where key information is recorded that can be mined. And this was just from the pre-EPIC system that we had, and we could show that it was feasible to measure frailty, the compliance was good. There was a good range of frailty, so across the different categories available from 1 to 9, we got a spread of data. So it was identifying heterogeneity in our population, and that heterogeneity was informative. And frailty was an independent predictor of inpatient mortality for long length of stay. And importantly, transfer into a DME ward. So for every point higher on the clinical frailty scale score, you had a higher odds of needing to come to one of those CGA wards before discharge. So in a way, that was explaining geriatric medicine and odds ratio. Like what we do is we manage the medical complexity, whereas other specialties maybe are focusing on, do they need an angiogram, getting complicated dialysis decisions right. We're doing medical complexity and CGA, and that's what these patients need in order to get out of hospital. When we got EPIC, we were able to then extend that work with more detailed information about the patient journey. One of the criticisms was this is just a kind of proxy for illness acuity, but we found that it wasn't. So we could put in all the vital signs and need scores, and we could show that whether you had a low acuity illness on presentation or a high acuity illness on presentation, your clinical frailty scale score still added value in terms of understanding how vulnerable you were to negative outcomes at the end of your admission episode. It wasn't all, however, about frailty. We also had the ability to go back and look at dementia and delirium, here labelled as acute confusion, and again show that these metrics added value in terms of identifying those patients who were going to be at risk of negative health outcomes at the end of their admission, really trying to help target who we delivered CGA to, who we try to mitigate and modify their health outcomes. Again, place of residence was important, above and beyond frailty, above and beyond dementia and delirium. Whether you came in from a care home mattered. They tended to come in more acutely unwell than patients from their own home, so they had a greater proportion, had high illness acuity scores when they came in, as measured by the emergency department modified early warning score at the time, which is a bit like the news score that you might have heard more of. So they were much more likely to be acutely unwell when they hit the hospital. And beyond that, the nursing home residents were much more likely to suffer inpatient mortality, and the residential home residents unplanned readmission following discharge. So this has helped us to sort of understand where we need to target resources and what we're trying to prevent. I'm particularly interested in medication. I'm sort of keen to prove Voltaire wrong, that doctors are not just people who prescribe medications they know little about to patients of whom they know even less. So it was quite interesting to suddenly realise that we had a digital record of all the prescribing that went on in hospital. And even at the level of service evaluation, we changed cholinergics, anticholinergics being particularly sort of problematic in the world of geriatric medicine because of their side effects. So the side effects of this group of medications that all have anticholinergic property are generally remembered as blind as a bat, mad as a hatter, red as a beet, hot as a hare, dry as a bone, the bowel and bladder lose their tone, and the heart runs alone, so tachycardia. But the bit that really sort of worries us in geriatric medicine is the mad as a hatter bit, because there are quite good epidemiological links between use of alcohol and incident dementia, which kind of makes biological sense since their pharmacological action is directly opposing many of the licensed anti-dementia drugs, which are doing the exact opposite. So we looked at anticholinergic burden in our patient population, and by now you can see we've moved on a bit in time, and rather than sort of 5,000 or 8,000 patients, we've now got 30,000 plus first admission episodes. So we're starting to get a bit more sort of big in terms of how much data we've got. And we looked at these admission episodes and saw that around a third of our patients were prescribed drugs with these anticholinergic properties, and 1 in 10 of those who were prescribed them had dementia or cognitive concern. So we get that sort of weird situation where we're often treating people with medications that do the exact opposite, one promoting cholinergic activity, the other being anticholinergic. So it's really helpful when you see this in such a sort of distilled version, having looked at the whole picture. What we were also able to show is that where care was led by a geriatrician, so in the hospital, if we look at admission and discharge anticholinergic burden, admission being the black bars and discharge being the lighter grey bars, by discharge specialty, you can see that where the specialty care involves care led by a geriatrician, which is geriatric medicine, and some of you might not realise, also trauma and orthopaedics, because in this age group, in the older adult age group, we share the care of our older patients with fracture with the orthopaedic surgeons. So where we're performing CGA, where our focused medication review is a really core part of that treatment process, you get the greatest reduction in anticholinergic burden from admission to discharge, possibly also because these are the patient groups who are most likely to benefit. We also found consistent links between higher anticholinergic burden and higher odds of 30-day readmission, which is consistent with what we know in wider evidence that around 6 to 10% of all admission episodes are precipitated by some kind of adverse drug reaction, and that rises to nearly 1 in 5 of unplanned readmissions following a hospital discharge. So that's all very nice. It's service evaluation. It's sort of telling us a bit more about the inpatient experience. We've sort of proven, and now lots of other trusts have also embedded parts of CGA into their digital electronic hospital systems. We can standardise the recording of information. We can facilitate retrieval of that information at scale, and we can get metrics that are really relevant to older adult inpatients. And I think they do offer an opportunity, therefore, to better understand the inpatient experience of older adults, showing the value of these assessments and helping us getting the right care to the right patient at the right time. But it's also about phenotyping. And now we can get much better an idea of the characterization and discovery of aging phenotypes, which is going to be important for future work, particularly when we're able to link some of this data with, say, genomic information, and really trying to get to the bottom of genetic influences and associations with aging phenotypes. And just a point at this point to make that this was possible because there were financial incentives to embed metrics relevant to older adults into our hospital EHR system at the time. So we were really aided in our aspirations by things like sequence frameworks and national initiatives seeking to improve the care of older adult inpatients. So then in the last sort of service evaluation, I sort of hinted we were getting up to 30,000 people. We were starting to think about this is a big data, and could we do more with it than we could do on our trust IT systems using our more traditional approaches. And with the support of the BRC, that led to clinical technical collaboration with MBOL's EBI. And the purpose of that collaboration was to see, as proof of principle, if we could extract this routinely collected healthcare data, analyse it outside of the NHS in a technical centre, and see if we could find hidden patterns that could maybe help us inform us about, in the future, clinical decision making. So the reason why we chose EBI as the partner was because they had the computational capacity and the technical expertise to analyse the data alongside mechanisms for safe and secure storage. And clearly an awful lot of preparatory work went behind setting up this study, which can best be described as a series of iterative processes. The first one with the technical team agreeing a data set that was granular enough to be able to be analysed to find those hidden signals, but not so granular that we could identify the patients. And that was the sort of iterative process that was really supported by research governance leads at CUH and the BRC, namely Helen Street at the time. The second sort of iterative process was with our clinical informatics team, where we really had to go back and forth to work out how to extract the data, because this isn't like traditional research data, which is curated at source and research ready on request. The other Epic in my life, Epic Norfolk, is entirely different. I make a data application and I get a lovely data set with an explanation of what a tool is. This was much more of a sort of iterative process, working with the clinical informatics team to find where the pockets of data were and extracting them. I would say that now, I think this is a much more well-oiled process, but I'm quite proud to have been part of this in the early stages. And I know that this project and other exemplar projects, some of which are being led by people in this room, have really helped to polish those research governance and clinical informatics procedures so the whole process works much more efficiently today. So what we ended up with, and I'll just briefly go through this, is a really detailed data set in terms of the blood tests and vital signs information, and on quite a large number of older adult inpatients. But in other regards, we had really broad brush data. So we only had top level ICD-10 code at this point. We then took those and focused on 23 numerical values for commonly ordered medications and commonly ordered blood tests and vital signs, so things like renal function tests and blood pressure. And we took those 23 numerical values and presented only those data on each day of the admission episode to a machine learning model called a hidden Markov model, which is a traditional type of machine learning model. And what that does is it takes those 23 blood tests and vital signs data and does a dimensionality reduction where it captures some dominant feature of the patient condition on that day and generates states. And we had 17 patient states that were generated, so reducing the 23 numerical values to 23 states output from the model, capturing some dominant feature of the patient condition on that day. We could then describe the inpatient trajectories of the inpatient episodes by assigning each patient day a state. The advantage of the hidden Markov model is that it's able to be interpreted clinically. So I could perform a clinical interpretation of those models generated by the technical team at EBI. And what I found is that I was able to clinically interpret all 17 states, and they broadly coalesced into three sort of types. States which were admission-like states. So they described the beginning, the sort of treatment or middle or discharge state of the patient. States that described what was going on at sort of organ or illness level. So states that seemed to be representative of the particular disease or condition process that was occurring. And states that were about the patient's physiological response. So here, with my best picture I could find of sort of an inflammatory type reaction. So that's the patient's physiological response to what's going on in their condition and treatment. And we found that some states were overrepresented in patients who survived the admission episode, here coloured the progressively green and yellow, and other states were overrepresented in patients who died during the admission episode, here represented progressively darker blue. And what was really interesting is that even though we didn't present, when I say we, the technical team at UVI, even though they didn't present any information to the model around the patient's diagnoses or the patient's outcome for admission, when we organised admission episodes according to the states, that created an inpatient trajectory that made biological and clinical sense. So if you look at the inpatient trajectories organised by whether patients survived the admission episode or whether they died, you can see the top bar is those who died during the admission episode. The bottom part of the chart is those who survived. Everyone sort of starts off a sort of murky colour on day one. Almost everyone is in the same state on the first day of the admission episode. But then the trajectories diverge. And the patients who respond to treatment and get better get progressively lighter green and yellow, and those who unfortunately do not get progressively darker blue. So despite not giving the model any information on outcome, it was able to organise a 23 blood tests and vital signs in a way that made clinical sense and told us something informative about the inpatient trajectory as it started to diverge on day 2 of the admission episode. And so this is very much proof of principle, but it sort of explains how perhaps in the future this type of information can be used to augment or extend clinical decision support tools to identify deteriorating patients, but possibly more likely, actually those clinically fit for discharge patients, and to alert doctors, hey, your patient's stable, they could maybe be looked after outside of hospital, early supported discharge pathways, and perhaps also models in the future using different metrics to forecast bed capacity and how much we're going to need bed availability. But this is obviously one centre. When we started doing this, no one was talking about secure data environments. Now these things are a bit more than concepts, they're becoming a reality. So federated analysis is not looking as distant as it was when we started this work. But I think if I asked the EBI team to come and run this on our IT system currently in Addenbrooke, I'd probably crash it. Theatres probably wouldn't like it. So real-time analysis and clinician feedback is a little bit way off with the infrastructure we currently have. And obviously, none of this work so far is telling us whether it's going to change clinician behaviour or ultimately end up in improved outcomes in patients. So clearly there's a long way to go before we really get impact. But I would say that alongside all the research governance and clinical informatics learning that went on with this project and others that I've been involved in, which has really helped to move the whole pathway forwards in terms of getting access to this data and operationalising it for research. We did do quite a bit of PPIE focus group work, and I thought that was really important because a big fear for me as a clinician when I started this work was that the data would be leaked somewhere and it would be awful on the front page of the Daily Mail, and I would be in massive trouble. Actually, as I've gone along, that's not my biggest fear anymore. My biggest fear is it changes the doctor-patient relationship. That people don't tell me things because they don't want it to go in the record, because they don't want it to go in a research study they don't know about. So it's really important to me to understand what patients and the public felt about us using the identified data for research without explicit consent. We're perfectly entitled to do it by the law, as long as it's de-identified, but it mattered to me as a clinician if it was going to affect the quality of my relationship with my patients. So this was very important work for me. And what was really clear from the PPI focus group work we did, which was facilitated by Amanda Stranks, who was a brilliant PPI leader at Cambridge BRC. What was really clear is patients did not want to be overburdened with unnecessary information, particularly when they were coming into hospital, potentially ill, worried about their health condition and their presenting complaints. They didn't want, even though they don't need to consent, they didn't want to consent either. But they did want to be clear what opt-outs were available, and they did want to be clear that this was happening in a transparent way. So they wanted it really obvious that this was happening. They wanted posters, a web page, somewhere you could go to get more information if you wanted to. They wanted us to emphasise the benefits, to spell out the safeguards, and to give examples of how it might lead to patient benefit. And so that very clear aim that it must be public knowledge that this is occurring. And so now, not just because of this work, but also because of the other projects that are going on around the campus and the work of Helen Street, Adam Loveday, the e-hostel team, and various other people, we have a really clear web page on the Cambridge NIHR BRC site about health data research that's going on. If you come out of any lift in Addenbrooke, you're hit with a poster that tells you in a very simple way what's happening and gives you a point of contact. Although I did notice that the point of contact is slightly out of date because we've scrapped all of the emails. So I have alerted Adam that we need to change this. The current updated address on there. So there is ongoing work. Another postdoc, Huma Demabaga, has been working with medications data, so I'm still keen to prove Voltaire wrong. This is unpublished work, so I'm going to talk about it with some caution because I don't want to make too much inference about it in case we change our minds downstream. But just to let you know that we have extracted medication features from the data set. We've mapped onto a sort of standardized coding drug ontology, the ATC code, which is basically an alphanumerical descriptor of the properties of a medicine that looks a bit like an ICD-10 code. I won't go into all the details because I'm conscious of time. I would say that we had to exclude some features just in case you thought we were getting a bit too advanced. In 2020, we're still prescribing leeches and maggots for our patients, so I had to remove those. I have personally also used them. You have to count the leeches in and then count them back out again. So we removed features like that, and also various other things that are not really medications. When we get down to it, we got to 110 fourth level ATC codes with a prevalence of more than 2% in the cohort. And obviously each code might represent more than one drug, but they will generally represent drugs in a similar pharmacological action. We can then start to describe what's very messy in terms of inpatient prescribing. And we see immediately our obsession with paracetamol, and almost every other drug is referenced, benchmarked against the amount of paracetamol we prescribe. But it kind of is a good sanity check. There's penicillins, quite strongly represented, antacid medications, cardiac medications. You can start to get a picture of what we're prescribing and how much in our inpatient population. So it promises to be quite interesting data. And if you apply some by clustering to see if there are any patterns in that prescribing data, indeed you do find some clusters. And I'm not going to show you all the different clusters and my interpretations of them because they may change, and this is work in progress, but essentially they do make sense. We get clusters around cardiac drugs, clusters around drugs used in chronic lung disease, clusters around drugs used in anaesthesia and ITU, etc. And we can also map those back onto patients. If we take the sort of anaesthetic cluster and look at that, we can see that those patients who are prescribed those drugs during the inpatient episode are generally discharged by surgery and have a predominant ICD-10 code of S, which is injuries and poisoning. It shocked me for a little bit when I realised that in this age group, the vast majority of operations are happening because people have fallen over and broken their hip or another bone in the body. So these are the patients looked after by also geriatricians and trauma and orthopedics. So this makes clinical sense. So we can look at the medications data and we can start to untangle what is a very complex set of data with hundreds of different prescriptions being started and stopped, and start to get patterns in that data that we can bring back to groups of patients that make sense. So this is ongoing work, and we've got respiratory clusters and cardiac clusters, but I'm not going to talk about it too much. What I would say is there is still quite a lot of black. And I think those are things that aren't really related to each other. And I think that does reflect the fact that this is a multimorbid population with medical complexity. And we've designed hospital systems to look after patients with single system disorders, but that's not how they're presenting now. You can get these single system treatment pathways out of the data, but there's also a lot of noise. And that's because the vast majority of our patients are sitting in hospital having multiple different things managed at once, and without the systems in place to manage these disorders, because we've designed the whole thing to work around single system disorders and single system treatment pathways when patients are now presenting with medical and multimorbidity. So just some reflections. I think I'm just running out of time. So I've made the case, I think, the opportunities and the potential of hospital EHRs to better understand older adult inpatient experiences, inform services and interventions, and maybe one day in the future help us to better characterise aging phenotypes as a substrate for future research. But there are some challenges around methodology in particular. Not all information is equally accessible. 70% of the data in the EHR is free text. Natural language processing is getting better, but there are more complex issues to consider around releasing the information in that free text data. Not everything is collected using gold standard tools, and not everything is standardized in terms of clinical coding. So there's a lot of work done around some diagnoses like cardiac diagnoses, but things like falls and incontinence, much more variability in how they're coded across different systems. But those are the things that are really important to my patients. We also don't have patient-reported outcome measures, really, routinely represented in osteoelectronic health records. And those are things increasingly being recommended as part of WHO guidelines and also the other records bodies that we should be including, but they're quite poorly available. Missingness, I didn't talk about missingness, in part because Angela's here, and I'm sure that I'll get it wrong. But one of the biggest challenges with the EBI project, with the trajectories, was missing data, because for that HLM to work, you needed a regularized data set with information for all of those 23 values on every single day, which clearly it doesn't exist in all of the routine records that we extracted. So the technical team had to work quite hard to define a cohort that had an acceptable level of missingness, and then ways to address that using both linear interpolation and multiple imputation to address that missingness. But there's a lot of challenges around missing data, because some of it, frankly, is not missing at random, it's missing very deliberately. Federation, I've talked a little bit about. From a DME geriatrics point of view, we really want to get social care data linked with healthcare data, because the two are so intrinsically linked in the care of older adults and older adult pathways, and also link it with relevant national audit and registry data, like the national stroke hip fracture audit and dementia care audit. And I talked a bit about inequity and why that drove me to sort of do my research, but I don't think EHR are going to solve inequity on their own, and they could also potentially exacerbate it. You can get algorithmic bias if you have data sets with underrepresentation of certain groups. And I've presented you solely data from Cambridge today. And I can tell you that my older adult inpatient population is about 99% white. So there isn't the diversity there in some respects that we would like. You can also perpetuate existing biases in the data. So I showed you that older adults on care homes are more likely to present acutely unwell, more acutely unwell, and then more likely to die. So an algorithm might tell me there's no point trying to treat them, they're going to die, don't bother. But actually, it's perpetuating what's happened in the community, where those care homes have been able to support them for longer, and therefore they come in a bit later than someone from their own home who's just trying to struggle on with their equally aged spouse and has come into hospital earlier. So rather than thinking, don't bother, what I interpret that data to mean is we need to be earlier and faster with our response. And just access bias and uptake bias, thinking more around who has access to trust with that digital maturity, and thinking more around digital healthcare generally, who is going to be likely to uptake systems as they become more electronic and have things like smart watches and apps and things linked to the healthcare record. And also external factors, shifting focus away from funding other research resources, which may have increasingly equity-focused methodology and be much more established in their fields of discipline than this relatively novel data resource. So I'm pleased to be part of the cross-NIHR collaboration multiple long-term condition methodologies work stream, which is trying to address some of these particular methodological challenges, and it's a really great team to be part of. And I'm also proud to be part of our Geri Data Collaborative, which is bringing together geriatricians, data scientists, and other professionals interested in harnessing this data for research, try and learn from our senior colleagues who've gone before us and shown us the way using primary care data, for example, the very well regarded electronic frailty index, and also helping to shape the narrative by writing opinion pieces and New Horizons articles on the use of this data for older people's health. So just going back to our patient very quickly, if we identify at the point of presentation someone with moderate frailty, concern about her cognition and polypharmacy, including anticholinergics, we can make sure that she gets early CGA to optimise her health outcomes. And so I think using EHR data, we can evaluate those inpatient pathways and better tailor them to meet the needs of our patient. And in the future, I hope that better phenotyping might help us discover more about those underlying biopsychosocial processes for further personalising treatment pathways and facilitating excellent and efficient care. And geriatric medicine is the largest medical specialty in the UK, so it's really important that we're involved. in using this data for research, and especially as AI and digital data become increasingly available. So thank you and questions. Sorry I slightly overran.